Okay, it's noon by my clock, so we'll get started. Thanks everyone for joining. So today we have a great presentation on medication optimization as the last webinar in the Pharmacy Prescribing and Climate Action webinar series via Cascades. We have lots of co-hosts, including where I'm coming from. So my name is Rob Hammett, and I'll be moderating today's session. I'm a pharmacist. My role is as the research and development pharmacist, primary care within Northern Health, and I'm also in a joint position with the University of British Columbia Faculty of Pharmaceutical Sciences, who is co-hosting this series along with all the other great organizations on the screen here. So today we have a great session on medication optimization. I want to first start with a land acknowledgement. So we just want to begin with a moment to acknowledge and reflect on the lands in which we are all joining from this gathering today. Cascades operates from coast to coast, and as a result, we are living and working on many different lands, which are the traditional territories of many different First Nation, Métis, and Inuit people. We also want to reflect on the ways in which healthcare has not been equitable or inclusive of Indigenous peoples and their ways of healing and knowing. We want to acknowledge that environmental healing begins with reconciliation and recognition of the damage that colonialism has inflicted on the planet. I myself am coming to you from the traditional unceded territory of the Kw'alae, now known as Prince George in British Columbia, northern BC. And so I just ask you all to take a moment to reflect on the space that you're in and how that might impact the people that were here before you and the healthcare that you might be providing. So, very quick housekeeping. The session is being recorded. Throughout the talk, I just ask that you use the Q&A function in Zoom to submit any questions to me. And I'll be reviewing them throughout the talks and hopefully have an opportunity to ask them to the great speakers at the end of the session here. We have three excellent speakers today, starting with Miles Sargent. So Miles is the postgraduate medical education lead for planetary health at McMaster University, the executive director of CCGH, the president of Trees for Hamilton, and the lead physician of the Hamilton Family Health Team Green Initiative. We also have Lisa McCarthy, who is an associate professor at the University of Toronto and co-director of deprescribing.org. And finally, Sarah Follis, who is a staff pharmacist and chair of the Sunnybrook Health Sciences Pharmacy Green Team, as well as a teaching assistant at the University of Waterloo School of Pharmacy. So welcome to you all. Miles, I will hand over the control to you and let you get started.
Okay. Is Ivy helping with slides? If so, next slide, please. Was there like an intro slide there? No? If not, I will carry on. So yes, I'm Miles Sargent. I'm a family doctor in Hamilton. I do still practice 1 day a week, believe it or not, both in inpatient and outpatient medicine. But I do climate work very much full time. And if you want to join our group or help us out, let me know. We could always use new help and volunteers. This is from the Lancet from 4 years ago, 2021. When I first saw this, it kind of blew my mind. I'm sure many of you have seen this before. Just quickly, this is the healthcare system in England in terms of the carbon footprint of their system and what makes up the footprint. And as you see at around 8 o'clock, building energy, only 10%, transportation, 11 o'clock, and green, 10%, supply chain, I think it was 62%. And the first 22% there is the production of medications, which is just such a shock. And then also within buildings at about 10 o'clock is the emissions from both MDIs and anesthetic gases, making it, I don't know, 27%, just crazy numbers. Next slide. So we were inspired by that article and other articles done in Canada and elsewhere. And we took that information and we phoned a bunch of hospitals about the costs of doing various things. And we tried to model things fairly to compare them, trying to compare apples to apples, if you will. This low-hanging peach tree is now 3 years old. We don't have next to nitrous on there, which is another orange fruit, which probably about cost neutral, maybe a bit of cost savings. Anyway, the big one here, which is relevant to today, of all these different initiatives you can take at your hospital, is deprescribing. So deprescribing ends up being one of the big fruits. Over 100 tons of CO2 saved per year for a 200-bed hospital, and saves likely over $500,000 if you can deprescribe by 5%. Sadly, that's easier said than done. Next slide. The graphic here is actually the journey of a computer. So take a look at that as I'm talking. I did come across this. It was actually when I was looking up medications, and I was curious why were medications such a big part of the footprint in their production. And so you can see a computer travels all over the world to get to us. So why do meds account for so much? I started out with a really lucky thing, sort of a family friend who was a VP in big pharma, 5 different companies, had retired, came over for coffee. We had a great chat. She was super excited. She was going to talk to all her pharmacy friends. Didn't get back to me. I emailed her a couple of weeks later with the subject line, "Who got to you?" I was kidding. She never replied. We had a ton of difficulty extracting data to find out about the journey of a pill, and I'll show you that in a minute. We ended up reaching out to McMaster University Engineering Department and had 3 thesis students work on this, master's students. Next slide. We picked clonazepam. That's the clonazepam molecule I'm sure you'll all recognize. So clonazepam, why do we pick it? It's overprescribed. It is habituating. It has several harms. There are safer alternatives. And for us, practically, it's a very old med. We thought it would be easier to find information than a newer med. Next slide. And one of the next things I did was look up the Pharma Compass website. This is actually quite an interesting website to look at. It's open to the public to look at it. So if you were a company producing medications, you would go to Pharma Compass to find where you could buy things around the world. Of course, clonazepam has an active pharmaceutical ingredient. We're all aware of that as pharmacists and docs and nurses. I can say that I did not learn anything about excipients in medical school. I've asked medical students recently, do you learn about excipients? I don't think they do. I imagine the pharmacists do. But the bottom line is, when you look up PharmaCompass and you look up the different generic companies that make clonazepam, there's usually 5 to 9 of these different ingredients to make essentially to make the pill more digestible. And every company does it differently and uses a different mix. Next slide. And as I think some of you have seen, we finally did publish Journey of a Pill. It was a long journey. It took us 3 years to publish this. And there are many, many different pathways here in terms of making a clonazepam pill, many possible pathways. This is one potential pathway. This was 63,000 kilometers. We did it based mainly on bulk, and so most of the active pharmaceutical ingredient and excipients are coming from Asia and getting shipped across to North America. There are actually opportunities in Mexico and Brazil to be producing meds. I'd actually like to look at the shortest possible journey. Haven't had time yet. After we published this, a bit of Murphy's Law, we had an insider reach out to us from Europe, who's an inspector of the pharmaceutical companies in Asia. He said, you know, a more common pathway would be a 53,000 kilometer pathway. So just being fair to Big Pharma. However, if you were to try to walk and swim around the equator, it would be a 40,000 kilometer trip. So in any case, the high bulk pathways would be 40,000 kilometers. I just talked to you about excipients. We didn't really even include excipients in here, just way too complicated. So that's not part of this pathway. And the other thing is we didn't include planes. I mean, this was all shipping in trucks, but as this inspector told me, Once the API is manufactured, the clock is ticking in terms of expiry date. So these things are often expedited by plane. Next slide. So St. Peter's Hospital, Complex Care Hospital, where I work, gosh, I feel like this is 3 years ago we were talking about it. I'm not sure if this slide is showing properly. Is the writing showing or not? Anyway, 2023, there it is. We looked at the medications of 32 consecutive patients on our wards. This was a QI project. Of course, we didn't know what we were going to find. And we found in phase 1 that our patients were coming to us from acute care on 19.1 medications each. The folks who work in acute care are typically not shocked by this. There was 13 regular meds, 6 PRN meds. Sarah, who's going to speak later, I think is going to dive a little deeper into this. She was part of that project. And they were discharged, this was the important thing, without us changing our practice on approximately the same number of meds. Why? Because we're busy and it's hard to deprescribe. It's a super sad situation. And so we thought, where could we improve in terms of classes of meds? And so these were the big 4. We were thinking we could do a lot better here. And again, benzos is on this list. Low molecular weight heparin was another one we looked at a little deeper. Next slide. This is the same England pie graph I showed before, but pulling out the primary care piece. And so we published this article, The Environmental Elephant in the Office, Medications, at the Canadian Family Medicine Journal a few months ago. And we turned that information into an elephant. And so for family medicine, pharmaceutical production is 48%, which is the body and the legs of the elephant. Water and waste is the tail. You can see how small that is in comparison. The ear of the elephant, MDIs and emissions. So again, 61% in primary care, which is massive. Next slide. A couple years ago, we made a national sustainable prescribing group, which you're welcome to inquire about, essentially thinking about how can we prescribe less, how can we put a green lens on deprescribing, and we do have all the big deprescribing groups at that table. In our first year, we made what we called options for the sustainable prescriber. So this is an outpatient infographic, not very long. I won't go through it all. You're welcome to look it up. Bottom line is, can you stop the legacy meds? Can you stop the meds which, once they get started, people are often on for decades? Levothyroxine, SSRIs, benzos, MDIs. You might start a teenager on an MDI when there might be a better option, and then that person takes the blue puffer forever. Next slide. The other thing we looked at, and if people are interested in working on this one with us, let us know. Over-the-counter medications, we don't talk about this one as much. And I know from a family medicine perspective, dare you ask your patient to bring in their bag of 30 over-the-counter meds? I mean, do you have time to deal with that? Somehow we do need to deal with that. I mean, in ways I would argue this should be easier in terms of decreasing these meds than prescribed meds. These are often, and again, you see here, $4 billion spent on over-the-counter medications in Canada per year. Does the physician pharmacist know what you're taking? Does the over-the-counter med have any evidence or indication to be used? And of course, this does increase polypharmacy and associated harms. Next slide. And this is a bit of good news. I expect within the next month, we will be coming out with UMaker Canada version. So UMaker, if you've looked this up, is based in England, and they do look at the carbon footprint of all the meds on the UK or the England formulary. So we are translating this to the Canadian formulary, and hopefully we get this out soon. Don't need to tell you, clearly, patient health is paramount. It needs to be safe for the patient. But if there are, for example, 2 PPIs, and there's really no difference in indication, and there's one which is a green one and one which is a red one, maybe you choose the green one. And that is all I have. I think I'm passing over to Lisa. Go ahead.
Thanks, Miles. Always a hard act to follow. And I'm really honored to be here today with Miles and Sarah to present some of the things that we've been working on. If we haven't met, my name is Lisa McCarthy, and I'm a pharmacist. I've practiced in a lot of different settings, acute care, primary care, community pharmacies, you name it, I probably tried it. And I'm coming to you today from Toronto. For thousands of years, Toronto has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. So my goal, whether I'm with patients, teaching, or doing research, is to help people have better experiences with their medicines. And my mission is to really ensure that people take what they need, no less and no more. And so some of the ways that I live that is as a co-director of something called deprescribing.org, which I'll talk to you about, and as a faculty member at the University of Toronto. I'm going to start with a bit of a confession first, actually. I used to think about like polypharmacy or appropriate prescribing, deprescribing, more at a per person or a health system level. And then I had the opportunity to kind of meet Miles and Sarah. And through the Sustainable Working Group with the Canadian Coalition for Green Healthcare and Cascades, I've been able to take a different direction in terms of how I think about my work. And it's really led me to reposition kind of how I talk about the benefits of deprescribing for everyone. And so simply put, my message is deprescribing is good for people, it's good for the health systems, and it's good for the planet. Now, when we were preparing for today's session, they're like, oh, you got to talk about deprescribing. And I quickly realized that like for this audience, probably you could define for me what deprescribing is in your sleep. And likely a lot of you have tips about how to manage it. So rather than kind of focusing on that nuts and bolts of that here, what I decided to do was tell you a little bit some new things in the space that may be worth checking out for yourself. Okay. Oh, I went too far. Sorry about my slide control. So first, I've got to plug deprescribing.org, near and dear to my heart. If you don't know us, what we do is we partner with clinicians and the public to create evidence-based tools and resources that help inform decisions about if, when, and how to stop or reduce medications as part of their overall appropriate use. And because tools are only useful when they're used, we also do a lot of implementation work to try and support their use in practice. So we're best known for our open access resources on our website that have been adopted across the world. Lesser known, we also have tools that help to support conversations about having medications, particularly in long-term care homes. And all of this is on our website if you want to have a look. We're best known for our 5 kind of guidelines and algorithms that are on the slide. We've also partnered with other countries on new ones, one in particular about opioids from Australia, that's complete. And altogether, our tools and resources have been translated more than 50 times. It's interesting, the latest is the Greek versions, which is really interesting to see the work in Greek. It doesn't really mean anything to me, but we're working on getting those posted on our site. The reason I raise it for you today is we're actually on the cusp of releasing a new guideline about statins. And hope that everybody will find that a useful new tool into our armamentarium. But if you're interested in knowing more about guidelines and what's being worked on, there's another one in gabapentinoids that's being developed again with colleagues in Australia, and another one about diuretics with colleagues in Europe. We have a registry called Depot on our website where people kind of sign up the topics that they're working on so you can see what's coming. Another hat that I wear is one as an executive member of something called the Canadian Medication Appropriateness and Deprescribing Network, which is a mouthful. So it's called CADEN. And if you don't know CADEN, we were founded in about 2015. We're a group of clinicians, educators, and people with lived experience, community leaders, academics, you name it, everyone's welcome. And our collective mission is really to produce, share, and apply information that promotes the safe and appropriate use of medicines, including deprescribing. And so at CADEN, we do that in a lot of different ways. Advocacy, a lot of public outreach at the local community level, education of health professionals, as well as the public, and through research. If you're in the education space, you may be aware, I hope you are, that we have an interprofessional curricular framework to support deprescribing. And we're really on a learning journey to decolonize our network. And partner with Indigenous people more strongly to understand the best ways of sharing messaging and understanding their medication experiences. Through our partnerships with Health Canada and now Canada's Drug Agency, we've actually been able to really expand the reach of CADEN, but there's a lot more work to be done. And we're just scratching the surface in terms of our partnership on the environmental front. I can't do this talk without a little bit of telling you about some of the stats about how we're doing in Canada. think about this. It's estimated that more than 750 million prescriptions are filled annually at a cost of about $37 billion Canadian. Now, this image that's on this slide comes from a report that was produced by something called the Canada Drug Agency Transition Office. And it has other stats in terms of some of the challenges that we experience in Canada related to the overuse of medications and potentially inappropriate medicines. So just to give you some numbers, in 2021, based on like CHI claims, 2/3 of Canadians over the age of 65 were prescribed 5 or more medications, and a quarter took 10 or more. The numbers are higher for women, for older adults, even older, like 85 plus, and for people who live in long-term care. Strikingly, nearly 42% of Canadians over the age of 65 were prescribed at least one potentially inappropriate medication, costing our health system about $1 billion. And that's looking at direct costs only. It's not thinking about the indirect costs related to consequences for people, our health system, and even the planet. Even more challenging until a few years ago, Canada was really behind other nations in terms of coordination of our progress. There was this report that's cited on the slide from 2023 that identified more than 50 different initiatives and groups that were working together on this topic, but many were local or regional initiatives, and we had a lot of important gaps, and we needed some system coordination. So skipping over a lot of steps, enter Canada's Drug Agency. If you don't know about it, Canada's Drug Agency is one of the pan-Canadian healthcare organization. They operate as an independent and not-for-profit group with funding contributions from the Canadian federal, provincial, and territorial ministries of health. They also do receive some fees from the pharmaceutical industry for specific things, but again, they're a nonprofit organization. And their goal is really to provide credible, objective evidence and advice to senior health system leaders about drugs, health technologies, and health systems to support the sustainability of our public health systems. There's a lot of origin stories about how, or a lot to the origin story, I should say, about how Canada's Drug Agency became involved in appropriate use. But it's been going on, since the first call in budget of 2019. There's been a lot of roundtables and consultations, which you may have been participating in. And you may also know that in December 2023, the organization that was formerly known as CADIF was announced to be transforming into the Canada Drug Agency with maintaining CADIS mandates and extending its impact in a few areas. And that began in September 2024. So one of those new areas is about appropriate use. And you may be like, oh, I'm a frontline practitioner. Why do I need to know about this? I think it's important to understand that there's a momentum around appropriate use of medicines on a number of angles that we haven't seen in Canada before. And so to me, as somebody who's worked in this space for longer than I'm going to tell you, because it'll age me, it's an exciting time. Now, in terms of when I've used this term appropriate use a few times. And so I am, full disclosure, part of an advisory committee that helped CDA come up with its new strategy around appropriate use. And this is one of the hardest things that we had to define. So they are talking about appropriate use as when patients, caregivers, and health professionals work together to choose safe and effective medications that are most suited for that person's needs and their goals to achieve the best health outcomes. They talk about appropriate use being important because there's so many types of inappropriate use. So they are looking at overuse of medicines, which is what we're talking a lot about today and what I care about deeply with deprescribing. But they also talk about underuse of medications in particular populations, and as well as inappropriate use. So for some examples, overuse is a classic. Let's think about antimicrobial resistance and how we sometimes overuse antimicrobials inappropriately. When they're not needed. Underuse could be, an example could be statins actually for reducing the risk of illness in people at a high risk of cardiovascular disease. So I talked about a statin deprescribing guideline that we're creating, but we also have underuse in particular populations. And then inappropriate use is actually an umbrella term, and that's meant to cover things like the long-term use of the benzos for sleep, right? Which we all know is a whole can of badness. So deprescribing is really conceptualized as part of the appropriate use of medications, or one strategy for dealing with inappropriate use. A little bit more like policy stuff here. I think if you haven't heard about this, CDA then has recently released a 5-year strategy for how they're going to try and help move the needle on appropriate use of medicines. And really, it's about supporting the public, patients, caregivers, us as health professionals, for those that are that, and policymakers to leverage all of the existing talent that exists in Canada and help us to coordinate our efforts more broadly. So connecting, it also is around helping us have better access to better data in terms of understanding where we're at. So I'm not doing justice to the strategy. I'd like you to go and have a look at it if you're so inclined to do that. In the last couple of slides that I have, I'm going to just talk to you a little bit more about some of the initiatives that you may not know about that we've been working on as part of the CDA group. So one of them is actually, you remember that I said there was like more than 50 initiatives that were like uncoordinated and regional. One of the first things that CDA did was to try and create what they call the appropriate use program map. And if you go on their website, you can actually search this directory now of several organizations, including deprescribing.org and Caden, that have part of their line of work related to the appropriate use of medicines. And so this is a great way of kind of getting a sense of what is out there and what are some of the different programs. And if you're interested in this space, what are some of the resources that you can tap into? There's also, this is one of the most exciting things from my perspective, there's actually something now called the Appropriate Use Coalition. And so a grassroots group of 13 organizations have come together to really help to try and synergize our efforts around appropriate use. So we are good individually and much better together, is what I would say. One of our first initiatives focused on long-term care, and it was about addressing the rising rates of long-term antipsychotic use in long-term care post-pandemic. So we were doing okay. We were high. We were doing okay prior to the pandemic, and now the rates are kind of back up where we were. So this involves creating a benchmark around a target for people to work to and programming to help support long-term care homes achieve those goals. And that's got benefits for everyone in terms of the residents, their families, as well as our budgets and the planet. So all of these things do matter. So look for more from the Appropriate Use Coalition coming out. One thing that's relevant for primary care providers is a new partnership, a campaign that's going to focus on polypharmacy. And when I'm seeing the names of some of the people here, I want to thank you for your contributions to this work. So this is a campaign, dual campaign for the public as well as healthcare professionals, primary care specifically. And it was inspired by ISMP Canada's 5 questions to ask tool, which you may know about medicines. So they went ahead and created a 5 questions to ask about my multiple medications. So like polypharmacy edition, but we didn't call it that, to help the public reflect and have conversations with their health providers. And so there's this handout which you can see on the slide, and then a toolkit that accompanies it to coach those questions. We also soon to be released have a 5 tips for managing polypharmacy in primary care, and that's something that deprescribing.org led the creation of with ISMP and CDA. And there will also be a handout and then a toolkit, and we focused on made in Canada resources and trying to keep things in a digestible format for people around what are some of the best practice tips and evidence-based practices for managing polypharmacy in primary care settings. So that should be released by the end of this month. And then Sarah, just a heads up, I'm almost over to you. The one thing I also wanted to flag for this group is if you're interested in all things appropriate use and deprescribing, we are hosting a conference called the International Conference on Deprescribing, which is an event that'll be in Montreal in April of 2026. If you'd like to join and you need to have, an abstract or a workshop or something accepted, the call ends on October 15th. So you've got just over a week to get your submissions in for that conference. But what I love about it is it'll be a conference focused on medication appropriateness, both in Canada and internationally. And it's a nice small community actually of people that are committed to this space. And so if you have resource, we would absolutely love to have you join us as part of that. So Sarah, that's it kind of in terms of my hot topics and deprescribing and what's going on. And I welcome questions in the chat.
Thank you, Lisa. That was an excellent presentation over showing everything that is occurring in the deprescribing landscape. So I am thrilled to now shift gears and share some stories and projects that our colleagues and clinicians across Canada are doing to improve medication optimization. And I have been privileged to be working with Lisa and Miles and over our work together in planetary health, talking about deprescribing, medication overuse, the environmental impacts of medications, I have come across these projects and I think they are quite incredible and they may inspire you to perform a QI project within your work setting or start a new program potentially. So to begin, I'm quickly going to, next slide. Thank you. I'm quickly going to just review medication optimization because this is the basis of all the projects we'll be discussing. Medication optimization is a patient-centered approach to improving a patient's medication regimen. The clinician may look at the efficacy of the regimen, safety, cost, and adherence. And most recently, clinicians are now even considering the environmental impacts of a medication regimen. One way to perform medication optimization would be deprescribing. So, deprescribing a medication that is potentially causing harm, potentially not showing any benefit, or maybe is no longer indicated. And we've kind of already touched upon that. And like Lisa mentioned, the clinicians here may be very much familiar with deprescribing. But medication optimization, contrastingly, may also include adding a medication for an untreated indication, especially if, let's say, non-pharmacological strategies are not successful or sufficient. We want to treat an untreated indication to prevent worsening of the medical condition, prevent any complications, as well as prevent any hospitalizations or mortality related to the medical condition. We can also simplify regimens, and this is one that I want to encourage people to kind of consider more often. So, for instance, simplifying a regimen would be considering the amount of total daily doses or even the amount of medications being taken. So, pill burden is a barrier to adherence. It is a consequence of polypharmacy. So, we want to help improve adherence and overall disease management by simplifying a regimen when it's appropriate. This can be the use of single pill combinations. And for those who have read the new Canadian hypertension guidelines, they do advocate for the use of single pill combinations for patients who are stable on their blood pressure medications to increase efficiency and tolerability. This can also be considered even with inhalers. So let's say we have a COPD patient who is on triple therapy, being our LAMA, LABA, ICS inhaler. We have the Breeze Try inhaler, which is 2 puffs twice a day, or the Trelegy Ellipta, which is 1 puff once a day. And this may be easier for people with COPD to just take the 1 dose in the morning and do not have to worry about that evening dose. And soon enough, we'll get also into the environmental aspects of the meter dose inhaler versus non-meter dose inhaler, but we'll save that for a few slides from now. Lastly, we have formulation considerations. This is something I'm trying to incorporate into my personal practice for medication optimization. Also with the goal of reducing waste and confusion and medication errors. So, for instance, if you are anticipating a patient to have a lot of dose adjustments, maybe for an antihypertensive medication, you may pursue a pill format where they can cut the tablet in half versus a formulation where they have a capsule. And if the dose is decreased from Ramipril 10 milligrams to 5 milligrams, a brand new prescription would have to be filled because you cannot use the 10 milligram stock to produce the 5 milligram dose. And now we risk the patient having the 10 milligram dose at home, as well as the 5 milligram dose at home, as well as we're now dispensing more medications and potentially disposing of the previous stock. As well as if you have patients who are at high risk of dysphagia, if you work in the long-term care setting, you may consider that a PPI or a proton pump inhibitor, majority of them are not able to be crushed, split, or chewed for those who would require crushed medications for dysphagia. But lansoprazole is a capsule that can be opened. So if you are anticipating that potential kind of medication regimen that would have to be crushed tablets only or capsules opened only, you may consider starting the patient on lansoprazole and risk the confusion of switching PPIs down the line. Next slide. So now we'll dive into the actual projects. So I was honored to be able to contribute to this project actually when I was finishing my pharmacy degree at the University of Waterloo. I did a rotation at St. Peter's Hospital with Dr. Miles Sargent, who was our first presenter here today. And he briefly mentioned this project, and I'm going to dive a little deeper. So the team determined the problem being polypharmacy. There's an increased prevalence of polypharmacy within the patients being admitted to St. Peter's Hospital, and noticing that this incidence is also prevalent within the community. The goal was to look at medication use trends by documenting all the medications at admission, so day 0, day 7, and day 90 or discharge, whichever one occurred sooner, for 32 consecutive patients that were admitted to St. Peter's Hospital's medically complex care unit. So for the results, like Miles has mentioned, at admission, the average number of medications prescribed for these 32 patients was 19.1. 13 of these medications were scheduled, and 6.1 were PRN or when needed as needed medications. On day 7, it was noted that there was a 20% of these patients had a sedative added to their regimen. And we wonder if that's possibly related to they changed hospitals. They have now been admitted to St. Peter's. They may have came from home. Wherever they came from is sleep an issue that is now being managed with a sedative within 7 days of admission. And is there other strategies we could have did first before adding that sedative and risking potential continual use and potential for the sedative to be continued on discharge into the community. We also noted that PPIs were added on day 7 in 13% of the cohort. And then on day 90 or at discharge, it was noted that 65% of the patients had their low molecular weight heparin discontinued. And noting this was a big kind of epiphany or observation for the team, noting that we do not, or the patients in this study were not continued on the low molecular weight heparin when they were discharged home or after 90 days, it was no longer needed. They were no longer acutely ill, and their risk for VTE or DVT was decreased and not deemed that they needed it. So as a result, the team actually met with the thrombosis team at Hamilton Health Sciences, and the DVT prophylaxis protocol was changed at the institution. Now, for patients who are acutely ill, they will be started on DVT prophylaxis, and this will be continued for 30 days and then discontinued. So this was quite a big change that came out of this quality improvement study, just looking at the medication use trends and prescribing trends and continuation trends within a 90-day or shorter admission for 32 consecutive patients. Now we have the medication information quality and safety team at Sunnybrook Health Sciences Center in Toronto. Their team a few years ago or a couple of years ago did a very thorough review of their pharmacy formulary and removed medications in hope to optimize management, treatment, as well as sustainability considerations. So for instance, they removed medications that had limited evidence to support their use. So that would be they removed docusate sodium from the formulary, and that if a patient would like to take it, it will now be a patient's own supply. They also removed medications where there is a more suitable or appropriate alternative that is more commonly prescribed. For instance, our valacyclovir tablets are prescribed, and the use of our acyclovir ointment for herpes is not typically recommended. For like the CDC recommends the use of oral antiviral treatment therapy over topical for genital herpes. So the acyclovir ointment was removed. They also removed desflurane from the formulary, and this is an anesthetic drug used for surgeries. And desflurane is a potent greenhouse gas emission. Um, so they removed that, given that there is alternatives that are more environmentally friendly and should be potentially used over desflurane. So now it is no longer accessible because it is no longer on the formulary and no longer used given these environmental considerations. They removed medications that have not been used in the last 3 years to reduce any purchase and waste of medications that are sitting on the shelves. And then, of note, they added non-meter dosed inhalers to their formulary. Um, and this was to help promote the use of the non-meter dose inhalers, especially if a patient is managed on a non-meter dose inhaler form at home and is stable on it. This will allow the patient to continue it within the hospital and have the opportunity to continue it and hopefully continue it beyond discharge, because when pharmacy substitutions occur in hospital, sometimes the one that they were managed on in hospital and now stable on is continued compared to the previous one. Next slide. We also have the anticoagulation stewardship program at St. Paul's Hospital in Vancouver, British Columbia. And their team, similar to an antimicrobial stewardship team, was trying to reduce unnecessary use of heparin in contrast to antimicrobials, with the goals of improving patient outcomes, reducing medication costs associated with the purchase of heparin, reduce nursing time, and improve the environmental footprint of the hospital. They hired 3 times a week or a 0.6 FTE pharmacist to be involved in the program and use the audit and feedback strategy to provide recommendations for patients who are at risk or low risk of VTE. They provided 236 recommendations within the first 6 months of the program. And within that time, they deprescribed about 68% of these recommendations were for deprescribing of the low molecular weight heparin. One patient did develop a VTE within 30 days of the discontinuation of the VTE prophylaxis, while 232 patients did not. In regards to the actual outcomes and what cost to build the program versus the benefits of the program, like I previously mentioned, they hired a pharmacist to contribute on this multidisciplinary team, and that cost around $70,000. In regards to greenhouse gas emissions, the team estimated that it was a reduction in approximately 90,000 kilograms of carbon dioxide equivalents, which is approximately equivalent to 3,800 propane cylinders that are used for backyard home barbecues. This calculation is related to the pig mucosa that is required to create heparin, but it is of note, it is an estimate due to the lack of information we have regarding the pharmaceutical production of heparin and low molecular weight heparin. They also saw a reduction in nursing hours. And initially, I was surprised by this, but then when I reflected on how a low molecular weight heparin dose is individually packaged, it is a syringe, the nurse would have to obtain the drug, unpackage the drug, screen the patient for any signs of bleed, administer the drug, dispose of all the waste associated with the drug, and then document the administration. It makes sense to me that if there is a reduction in unnecessary use of heparin, there would be a reduction in nursing hours associated with its administration. Lastly, they saw a reduction in the cost or the pharmacy department's purchase in heparin. So that was equivalent to about $76,000 in cost saved for the amount of heparin, given we're not providing unnecessary or less doses. And of note, when we look at that, it cost around $70,000 to hire a pharmacist to be part of this professional team for the program, and then they had about a cost savings of 76,000. So those are quite similar numbers, but then we also have these additional benefits for patient outcomes, that they're not receiving a medication that is indicated, or if they're considered low risk, and they use the improved VTE scoring to assess the risk of VTE. And then we also have the reduction in nursing hours and CO2 equivalents. Sorry. One other and final project that I want to highlight here is an initiative that is being brought to clinicians across Ontario by the Canadian Association of Pharmacy for the Environment. This group is writing an open letter to the Ontario Ministry of Health, advocating to remove the limited use code or barriers to non-pressured meter-dosed inhalers, MDIs or PMDIs. The goal is to remove this kind of code that is limiting the open access and coverage for this medication. And this is in alignment with the new Canadian Thoracic Society guidelines. Specifically, binosinide formoterol, also known as Symbicort inhaler, is now indicated as a reliever in those 12 years in age and older. And currently, the LU code is only requires the LU code allows coverage if the patient is on a daily inhaled corticosteroid already and remains symptomatic. However, the new Canadian Thoracic Society guidelines also support the use of Symbicort or binosinide formoterol if the patient's unlikely to adhere to inhaled corticosteroid, and if they have a reliever that also has the ICS, that is preferred. It is also recommended in patients who are only requiring a PRN SABA but are at increased risk of exacerbations, as well as for patients who are well controlled but would just prefer to have this one inhaler and better asthma control. So this initiative is trying to remove all barriers to these dry powdered inhaler options for patients with asthma in Ontario. And for those who are wondering, how is this medication optimization? One inhaler that can be used for the maintenance and reliever therapy for a patient with asthma is more convenient and easier to adhere to. If you're going on a trip, now you just have one inhaler to pack versus the two. Only one inhaler to refill versus two, making sure you have enough doses. This is a more convenient option that is evidence-based. And given that some of these projects are a bit more institutional related, I thought I would share the primary care peach tree. Miles previously earlier today showed the institutional one. Here I just want to give those who work in primary care on this call today some ideas of what they can do within their practice. So we have the MDI to DPI there on the right side. It is an orange fruit, meaning it can be a game changer within the greenhouse gas savings per year, and cost to implement is kind of up there. It's usual practice kind of pricing, and cost to implement in hours is written there around like 15, let's say. We also have avoid unnecessary testing. And most recently, I kind of want to highlight that countering misinformation or disinformation is in the top left. And I know that there is a lot of information currently going out regarding Tylenol. And as we approach respiratory season and vaccination season, these are opportunities for primary care providers as well. And knowing that not only is it improving patient care and patients, but it is also potentially helping the environment. And I do want to note as well for the MDIs to DPIs, before doing so, you always want to double check the patient's ability to adhere to the inhaler, because that is the number one thing that will help control their respiratory disease is proper adherence as well as proper inhaler technique. And there's lots of resources online. I can share them in the chat later if needed, if you want to pursue those. And then lastly, circling back to what Miles said, reducing these OTC medications is also a way to help not only the planet, but can be beneficial if you take time to make sure the patient's medications and OTC use is appropriate. Now it looks like we have about 10 minutes for a little question and answer discussion.
Thanks so much, Sarah and Lisa and Miles. Really appreciate all of your presentations. There are a couple of questions in the chat that I'll go over. Lisa's answered most of them, but it might be good to reiterate some of them. But before we jump into that, Miles, I wonder if you'd be interested in answering the first question that I have for you. Both you and Sarah have presented the peach tree low-hanging fruit, and I'm wondering if you could just have, a favorite one of the months that you like to tackle, or one that you find, is really easy for you as a clinician to deal with.
Yes, Ray, I wasn't keeping up with the chat. So, golly, well, I think I'm going to say end of life, goals of care conversations. And clearly those can be in hospital, should be in hospital, but they can also be upstream, and they should be upstream. And I mean, as many of you know, have seen me talk before, I often do ask the question, where do you want to be when you die? And there's a reason I ask that question, because inevitably when I have a show of hands, no one puts their hand up for hospital, or at least not yet. One or two have said nursing home, long-term care. Everybody says hospital, or they just don't put their hand up because they don't want to think about it. And so the point is that we have a system where people do end up in hospital, and they do die in hospital, even though 87% of Canadians say they want to die at home. So we have a really, really broken system. I don't understand why we spend so much of our budget on hospitals. I believe home care in Ontario only gets 3% of the budget. I might be slightly wrong on that, but I believe it's roughly that. There are probably much bigger political forces at play that make us kind of go down this path, even though, when we have, I think, is it 18% of our beds in Ontario are alternate level of care beds, meaning people are being discharged either to long-term care or home, but they don't have a bed or a place to go to. Home, they don't have enough support. So hospitals become like a parking lot. And our response to that is to build bigger ones. So anyway, so that would be, Rob, to answer the question, that would be the fruit. I'm not saying it's an easy one. And, I've had a bit of an unusual family medicine practice in my life because I have been within the shelter system for my career and in the hospital. So I don't like to tell clinicians what to do when I'm not really living in their shoes. So I do talk to my family doc friends and say, how is this possible to have upstream conversations? And some of the advice people give me is that this doesn't have to happen in one conversation, right? Like you plant the seed, maybe you book another appointment in 3 months, and there are opportunities that someone has just been discharged from hospital, someone has a new diagnosis, chronic illness. There are opportunities to have these difficult conversations. So thank you for that question.
Yeah, thanks, Miles. Appreciate the answer. Lisa, there's a couple of questions maybe directed towards you, just regarding, the CDA or other organizations incorporating the carbon footprint or other footprints of medications into their decisions. You've provided a little bit of an answer in the chat, but I'm wondering if you're able to expand just a tiny bit.
Sure, I can do my best, which is for people on this call, you'll be happy to hear perhaps that, like, the environmental implications do get discussed at those kinds of tables, in terms of, doing this is all good for the planet too. That's probably as far as it kind of goes. There are some organizations moving it further. I mean, Choosing Wisely Canada has tried to create a bunch of climate conscious recommendations. There's some work at Caden going on in terms of, like, talking about the environmental impact of medications and raising awareness. And certainly Kathy and the groups that Miles leads are doing tremendous work in this space. I think there's a lot that we still don't know about how best to do this. So some of the questions about, like, are they incorporating environmental considerations into formulary recommendations? Well, Miles and I have had conversations. Sarah, I've had conversations about that as an idea and how that happens. And there's a lot we still don't know. But I think, Miles, we're going to follow up about UMaker so I understand more about what's going on and how close that is to actually being able to do those things. Because that's been the gap. Is like there's great ideas about how to do it, and then it's the actual nuts and bolts of how to get it to practice. As somebody rightly said in the chat, 3 years to come up with clonazepam. Okay, so how are we going to do that on a system level for the thousands of medications that we actually have? Maybe there's more than thousands. So I would say that there's absolutely the kernels are being planted, and so that's a great idea. How close that is to actually like being implemented into making decisions, I think there's still a lot we don't know. But please educate me if people have more.
Having looked at some of these resources and just the dearth of information that exists on the actual cost or impact of a molecule going from some factory somewhere to the patient's home, it is often very difficult to wrap your head around what that cost might be, but you can be guaranteed it's not zero. And so even if we don't have all of the information that we might want, you can still feel confident that the impacts or the interventions you're making are going to be beneficial to the patient and planetary health generally. Sarah, this last question might be directed towards you because you've presented a number of QI projects here and you seem to have a good understanding of what's going on. I'm wondering if you can answer Nicole's question. Are you okay? Just
Sure.
regarding are you aware of any projects that are looking at underuse as a sustainability project? Because we have seen some data that indicates that undertreating is worse for the planet. And so an example would be if you aren't using guideline-directed medical therapy for heart failure, say, and then the person gets an exacerbation and then has to be hospitalized, and there's all kinds of consequences from that happening. So just wondering if you're aware of any projects in that frame.
Yeah, happy to share. And sorry, I have a room booked and someone came in for the next meeting. So that's why I had to look to the side and
It's
ask
all
her
good.
to have 4 more minutes. So in regards to underuse, I don't know currently any projects. Lisa and Miles can chime in if they do or if they know of any, but I do know that people are looking at the environmental impact of hospitalizations and how hospital beds in themselves have a very significant environmental impact. Kind of going back to what Miles was talking about, dying at home and dying in a hospital, the environmental impacts of passing at home is significantly lower than one in a hospital. And for undertreating medical conditions that can really be related to hospitalizations, that is kind of where I think the project could occur, is noticing these patients are being undertreated and then consequently are having a hospital admission and having a prolonged stay or a short stay, but that has an environmental impact in itself because each bed has that kind of carbon dioxide equivalence. And Miles is our math guy, so he might be able to rhyme off the numbers, but that's where I haven't seen an official project as of yet published or in the space. Um, Sometimes it takes time to inform others of these projects. It takes, for instance, the St. Peter's one took 3 years to do and then kind of get the awareness out.
Sorry, Sarah, a project in terms of the footprint of a hospital?
The question was, is there any
Yeah.
projects looking into the underuse of medications? And I said, I don't,
Mm.
and the environmental
Oh, okay.
impacts of
I see.
undertreating. And I just said, I'm not totally sure about
Okay. Okay.
that,
Fine. Yeah.
but
So
undertreating
yeah.
can lead
So
to the hospitalizations.
yeah. Yeah. Absolutely. Yeah. So I wrote an article with Owen Lau back in January or February. If you look up my last name and spell it like the military spells it, and look up a kilo for a ton, you'll see that article. And it was the concept that we also have to remember that underuse is a bigger problem than overuse. And so vaccines are a great example of, yes, the vaccine won't have a full kilo of carbon, but it'll have a footprint. but in the long run, you are going to be saving a ton of CO2 population-wise down the road. We did put that on the Peach website, Peach Health Ontario website under ECHO orders, ECO orders. And we've shown examples from different specialties about great examples of underuse and what we could be doing in our different disciplines. And Lisa, Sarah, it'd be great to get one for pharmacy. Yeah.
Thanks, Miles, and thanks to all of our speakers on their presentations today and answering all these great questions. I think this is a good time to close the session as we're very close to the top of the hour here. I just want to put a small plug for the Cascades Medication Optimization Playbook that Katie has added to the chat here, and all of these presenters were contributors to, so please do have a look at that. As a reminder, this session was recorded and will be available on the Cascades website shortly, as will the other previous Cascades webinar series. So please have a browse through those and give them a review when you have time. I think that's it. Thanks for posting that link again. Thanks so much to everyone who's been involved in this. I really appreciate your time, and it's been a great learning session. Take care.